Hello and welcome to financialexpress.com. I am Sushmita Pandya. Malaria, often known as poor man's disease, is a life-threatening illness that is caused by parasites that are spread through humans through bites of female Anopheles mosquito. Although this disease is curable and preventable, people often suffer a lot due to lack of basic facilities, especially in countries like India. According to WHO's malaria report 2021, there were an estimate case of 241 million and deaths of 6 lakhs 27,000 across the world. To talk more about the status and challenges of malaria, today we have with us Mr. Pratik Kumar, country head, Malaria No More India. Mr. Pratik Kumar, thank you
Hi.
for joining us.
Hello. Hi. Pleasure to be on the show.
So to begin with, there is a tendency among people that since it's spread through mosquitoes, people tend to group it to dengue or chikungunya. What exactly separate this disease from other vector-borne diseases?
So there is a spectrum of diseases in the basket of what we call vector-borne diseases, and malaria just happens to be one of them. So there is dengue, there is chikungunya, there is Japanese encephalitis, there are several others, kala azar. Not everyone is also, has the mosquito as a vector. So kala azar, for example, is another. It's a fly. But together, they kind of, as a composite, get treated as vector-borne diseases because there are vectors, so the external carriers, which is what a vector is. If you specifically look at malaria, dengue, chikungunya, it is again the mosquitoes that are responsible for it. But then there are different mosquitoes, and the way the disease manifests in humans are also different. So while in case of malaria, there is a parasite which is responsible for the disease. In case of dengue and chikungunya, there are viruses. So different viruses which again reside in the body of a mosquito, and the process is fairly similar. But the way the disease manifests in a human body and the cures regarding it, they vary substantially. But the way in which kind of the vector is still the common enemy here. So we still have mosquito as the common threat for all these. And in case of kala azar, of course, it's a fly. But as the name suggests, that these are all brought to a human being through a medium, and this medium happens to be the vector in this case. It could be a mosquito, it could be a fly. But the most common of them is still happens to be malaria. There are a lot of incidences of malaria happening, and it kind of happens literally throughout the year. Where in case of dengue, chikungunya, you have it in bursts, and there are different reasons for it why you have them in bursts. But as common citizens, we still have to be aware of all this, irrespective of whether it's a dengue mosquito or a malaria mosquito. We'll not be able to distinguish, and hence all the precautionary measures and all the other measures have to be taken without really a knowledge of what might be the parasite or the virus inside the mosquito. Because naked eyes, it's very difficult. You need a trained eye to even detect all that. But then again, not every mosquito that bites you would also be carrying, say, the mosquito parasite, the malaria parasite. So we just have to be careful about mosquitoes. Not every mosquito is dangerous. That's also a fact. So, when people talk about that, kill all mosquitoes and then we'll be safe. No, that's not the way to go about things, because we will be actually impacting a food cycle, because mosquitoes are food for several organisms, and it's a part of the food cycle. So you can't eliminate one link of a chain, what is called the food chain. So yeah, that's broadly the answer.
So, as the report suggests, the recent malaria report, there have been a slight decline in cases in India. But still, majority of the India still shares the majority of the burden. As if we talk about death due to malaria or cases of malaria, what are the, according to you, since you and Malaria No More has been looking at malaria at a wide, at a different perspective, you have been treating, you have seen the issues. So what are the possible causes of this statistics of malaria in India?
Mm. So malaria in India has really shown remarkable improvement in the last few years. Remarkable improvement. Although we still continue to be the highest burdened country as far as South Asia is concerned, but the fact also is that we are also the largest country in South Asia. Uh, there are a lot of countries which are much smaller to us in Africa that have a much higher burden, and India is doing way better than, say, what it was doing, say, 5 years, 10 years back. We are in a space where the upward curve in terms of, I would say, sorry, the downward curve of malaria cases is really a trajectory to be very proud of. The cases are really coming down. Uh, the official figures take the deaths for, say, last year to less than 100. So it is really low if you consider the population size of the country and the fact that there used to be thousands and thousands of deaths, pretty, in the very recent past as well. What Malaria No More also believes is that we might not be looking at the true picture of what the actual cases might be, and it's not just us. We kind of to a certain extent also look up to WHO figures who have their own methods of tracking and estimating numbers. And those numbers consistently over the years have been several times more than what is reported by the government of India cases. Now, the first discrepancy we feel in terms of these numbers, even if the fact that they have come down, and we are definitely not disputing that the numbers are coming down, and which is a very good sign, and that is also a reason why we feel we could get into the elimination phase of the malaria program. The figures that the government collates is all coming in from the public sector. So these are all government institutions that report figures. So the way it works is that have the last mile ASHA workers who who conduct some tests, and those tests basis whether they're positive or negative, they get collated on paper-based systems. And then there is a whole hierarchy from sub-center upwards to PHCs, CHCs, and district hospitals, all the way to central and the national collation. The way it works is how this data collected. And once the collection happens, you arrive at certain figures and facts around what are the numbers, what are the cases, what are the trends, and so on. So while this trend has been on a decline, we feel that because a large number of people, especially in the far-flung areas, not necessarily going to public health settings. In a lot of cases, even the private health setting is actually a very informal setting. You don't have formal private structures that are, getting malaria cases. Just to give you a sense that, we work in these very far-flung areas of Koraput and Malkangiri in southern Odisha, where, you struggle to find 10 MBBS doctors, but you can find 1,000 quacks and RMPs. And they do end up getting a lot of malaria cases because in these settings we can't expect the poor tribal to actually find a qualified doctor, and it could be far removed from such locations. Travel could be a problem, or maybe just no resources to access the services. And even if he or she could, where are the doctors? So there is a large numbers that go to the formal and the informal private sector. And these numbers never get reported into the system because there's no mechanism to capture it. So even the National Family Health Surveys over the years tell you that almost 70 to 80% people go to the private sector, formal or informal, but they actually go to the private sector. And drawing the same analogy to malaria health seeking behavior as well, it will be prudent to assume that a lot of people actually go to the private sector and not public health systems. They eventually might go there, a larger percent eventually might go there once complications arise. And then they'll probably try and seek treatment of a higher order, whether from the private or the public sector. But we are definitely missing out a large number of them. And overall, I think the country is doing very well. We are on a trajectory where we should be able to at least control the disease. And with adequate programming and intervention steps, we could actually work towards elimination, which has been the goal of the Honorable Prime Minister who set this up way back in 2015, that by 2030, the country should be malaria free. Uh, as per WHO norms, we then require that by 2027, we go down to zero cases and stay that way for 3 years before the country is certified malaria free. Now that gives us a window of about next 5 years where this has to happen. And a lot of things have to be done differently in what is called a control phase of a disease versus an elimination phase of a disease. Elimination literally means that every single case has to be taken care of, identified, and the parasite killed so that there's no further transmission that is possible. So we are quite far from there, but the country is attempting that. And as Malaria No More, we are here to support the government, state government, and the national government to enable that vision to eventually come true.
So, as you mentioned that there is a lot of gap between the control from going from the control phase to the elimination phase. According to you, ideally, what should be the steps to fill in this gap to finally achieve our goal of making India malaria free?
Right. So when you look at a control phase of a disease, you're talking about basically a very large number of cases coming through to you. And in that way, your first step is normally to just reduce the number of cases. So today we are in the entire country, you are having different geographies at different stages of the elimination process. So some districts and some states are what we call at high burden, and there are more malaria cases thereby. Some of them are at the mid level, and some of them at the low level. So we define them as category 0, 1, 2, 3 states, 3 being the highest and 0 being the ideal, towards elimination. The entire country is kind of mapped out like that, and uh, wherever we have a higher number of cases, we have to first ensure that the disease is controlled, which basically means that if you have a very large number of cases, we have to reduce the number of cases. That is what is called the control phase. And there are specific actions that go along with it. The other side of the spectrum is what we call the elimination phase. Now, when we seek elimination, we basically want that there is not a single case of malaria that is ever spotted. So when a geography, when a district or a state kind of reaches that situation, you are supposed to track down any one singular case that might have cropped up on your radar. So firstly, to get to that, you need to have what we call almost like a real-time reporting system. You can't have a reporting system, which is currently the case, where the lag times are almost like 1 month. So the ASHA might do a paper-based reporting, and by the time it gets collated onto the national system, you have a lag time of a month or even more. Which means that if a response has to be planned around it, you are already late by a month. By which time the parasite would have done a lot of damage to the system. In contrast to that, when you are looking at elimination, the moment you track that one system, one case somewhere, you need to immediately do that, do a localized survey, try and see where the reservoirs are, who else has come into contact with this person, and is there a possibility of that spread going even further, and so on. And you have to literally shut it down then and there, which means the response times has to be very quick. The infrastructure through which data gets transmitted and the responses come through has to be very, very quick. And that is a real game change that has to be brought into the system if the country has to move from control to elimination. So while we are still far away from making it possible, we have reasons to believe that the government is very, very serious about it. And going forward, there will be systems and processes in place to ensure that the elimination journey is a reality.
So you mentioned that you talked about Odisha and you have been like on a ground level, on a like upper level, you have been witnessing the in and out, everything, all everything comprising malaria. So if I talk about state-wise distribution, because India changes every meters, every kilometer. So if we talk about implementing these things state-wise, so what have you witnessed state-wise? Like there are certain pros and cons of every state. So what you have witnessed state-wise, challenges you have witnessed state-wise, and also that what have been like Malaria No More's key challenges and key milestones that you have come across over the years.
Let me answer the first question first, because the second question is as a different discussion altogether. Uh, so health is a state subject, and states are free to create their own, do their own programming, as it were. But having said that, funds still come from the center. The bulk of it comes from the center. So there are national guidelines to be followed, and that's the way it has been. I've been more closely associated with Odisha because for the last 5 years, we are working with the state government under an MOU that has allowed us to, look at the state a lot more closely. Now, when we entered the state way back in 1780, Odisha was the highest prevalence state, and today it has come down to the second or the third. And this is as per the regular government data, and it was a very high level of infection that we were looking at. Almost like 40% of the infections were coming from Odisha, as far as the country is concerned. Today, Odisha is lower. Uh, to my mind, a few things have worked. The first, that the Odisha state government has inherently taken a lot of interest on malaria. They have a program that looks at eradicating malaria in the most far-flung regions of the state. And as a forested state and a large state with areas that are really cut off for various points of time due to rain and other reasons, there are several pockets that never received the medical attention that it should have. This is a case with almost all states of the country. It's not to say that Odisha is the only one like that. But then the government made special, efforts through the Daman program to do mass testing, which was something that was not even prescribed as an approach as far as government is concerned. So that the Daman program really helped in allowing in locations that would otherwise go untapped. So the way it works is that if I have fever, I would normally go up to an ASHA worker and get myself tested. So it's not a proactive process, it's a reactive process. I come up to you, I'm the ASHA worker, I test you. If you're positive, you get into my database. If you're not, of course, you still get into the database, but it's not a case. The Daman was a program where you proactively went out to seek whether there are parasites available in blood streams, whether or not you are manifesting fever or not. So there was a lot of mass testing done, not necessarily with people who are currently having fever. And we realized that there are a lot of cases like that as well. So people not manifesting fever, but having the malaria parasite, which we call the hidden burden, which I can talk about later as well. So it's not that everybody who has malaria necessarily has fever, and because you get the fever, you go and get tested for malaria. So Odisha government proactively tested a large number of people through its own resources, and which was substantially more than what the resources that they were getting from the central government. Then they worked very hard with the ASHA workers, and I can tell you that the ASHA workers in Odisha are far better trained on malaria than several of them in the neighboring states. And I'm talking about Jharkhand and other states where also I have had a sense of having interacted with them to see the amount of training that they've gone through. The third is around distribution of long-lasting insecticides. So these are insecticide nets that keep the vector away, and there was large-scale distribution happening in Odisha, whereas several other states like UP probably did not get to receive any, and it's now one of the top states. So there are these policies at the national level which allows certain vector control measures to go to certain locations and does not allow that in other locations. So there are a lot of these dichotomies, but the point here really is that Odisha really succeeded because the Daman program, ASHA training, LLIN distribution at the last mile, and lots of diagnostic kits being made available to the ASHAs for testing and treatment. And of course, the treatment part, of course, is a medicine part. But unless you test and you test enough, how would you know whether somebody is carrying the parasite or not, is living with malaria or not? I have strong reasons to believe that not enough testing kits go out there in the market, and ASHAs are not getting enough kits, and even if they did, malaria is not so high on the priority of even from an ASHA perspective in terms of the incentive that they get to test malaria. So it's a vicious circle where all these factors combine, and certain states do better and certain states do not. But I think everything boils down to intent. It is about the strength of the health infrastructure. It is about political will. It is about provisioning assets and technology, and getting the reporting systems in place so that the right information comes at the right time, and the whole together this whole thing can address malaria.
So, you mentioned that the Odisha government took interest, prioritized malaria. Don't you think that it comes down to the to one point that there is a need to prioritize, that not enough prioritizing is happening in at government level, and another thing that there is also that we see that ASHA workers face a lot of issue. They are facing incentive issues. So it's, as you mentioned, that it is a vicious cycle. So do you think, according to you, can you suggest some ways that we can get out of this vicious cycle? Because if we talk about like in a normal way, so if we say ki malaria is important, so people will say we have a pandemic going on right now, but it's like that we are pushing one problem at one point and just move on to another problem. So how, according
Mhm.
to you, can we manage all of it to make it a ideal? Obviously ideal is not possible to address all of it properly.
Right. So there are no ideal solutions. I mean, we have, as a part of our history, having enough examples of some disease control programs or some epidemics kind of outshining or shifting the priorities of existing programs. And COVID is just one example. It's an extreme example. We know that nothing like this has ever hit us before, at least in the living memory. Uh, while that is an extreme example, the fact is that malaria suffers from a lot of other perspectives as well. One of which is that nobody wants to report malaria. It is a political issue. So I have formally and informally spoken to a lot of health workers, health officials, municipalities, and others. When it comes to malaria, dengue, chikungunya, people don't want to talk about it because that is one issue where it's almost inevitable that the buck will fall on the person who's heading the health portfolio or the municipal program, and then that, or the health program, and then that, and it is treated as a negligence on his or her part, and immediately you are shunted, or there'll be some political move to make you feel that malaria is literally your responsibility. So there's this whole ecosystem that tries to not talk about it. And when you do not talk about something, the chances that the seriousness that it deserves will also go down, because then you're not reporting enough. And if you're not reporting enough, so in a country like India, 100 deaths in malaria means that really nobody is dying of malaria. Really, nobody. And I think there could be many, many more than that. The WHO report itself feels that way. And so if there are not enough people dying of malaria, so if I'm a bureaucrat to, try and distribute my meager resources, I would see that, okay, my program is doing fine. The numbers are going down drastically, whether or not I'm putting enough effort on it or not. And if this is the trajectory, eventually it will just go off and, it will take care of itself. I don't need to do much. So why do more? Why allocate more? There are enough other pressing issues to look at. So this is what, reporting does to you as well, because decisions are then made based on what gets reported, how much discussion and dialogue happens because it gets reported. Dengue chikungunya still gets some, I would say, traction because it kind of happens between you and me, which means it can literally, happen in an elite home, and it could be life-threatening. Malaria kind of happens and comes and goes, and you have, it's curable, it's manageable, so not much to worry about. So there are several reasons why it does not get the primacy it deserves. Having said that, if you look at it from a different lens, polio was not eradicated because it was killing people. There were a few cases, and of course, it's an emotional issue with children getting it and so on. But so are children are getting malaria. Pregnant mothers are getting malaria, but nobody seems to talk about it. And we were quite fixated on, eradicating that one polio case that ever came up, say, in a UP or somewhere. So there was a certain intent that drove the polio virus away. We need something similar for malaria, and it's not entirely always about the number of deaths and cases, which I'm very, very sure is underreported. And this happens across the board. There are cases when you have months and months in a large state like Bihar and others, there's just no malaria reporting happening. And it's impossible to assume that such densely populated and underdeveloped states will have no cases. But the point is that if nobody is reporting, nobody is collating, and nobody is finally putting it out there on the net, it does not exist. And that's a reality we have to live with. And that's where strengthening of data, strengthening of systems becomes a very, very important piece of the whole puzzle. We are working towards it, and we hope that with more and more transparency coming into the system as far as reporting is concerned, and hopefully as soon as we can get the private sector to come and at least start reporting some of it. We all know that the informal private sector will not report, and we don't want them to report. It doesn't really help, because that's kind of very loose. But there's enough and more that the country can report. And the day we start serious reporting, we start addressing the disease the way it should be addressed. Yeah.
So you talked about bringing in private players. So like in a country like India, where there is a huge gap between rural and urban people, like people who have hospitals at very far off places will, as you said, that they will go to nearby quack, or nearby doctors or medics. So what are the why, according to you, only public sector figures are being reported, and why, if we know that, if we have if we are aware that private players also have private hospitals, formal, informal, they also have huge chunk of malaria cases, so why we can't incorporate that? What are the reasons, according to you?
This is a question best meant for the government. We can only state that people go to both sides. They go to public sector, they go to private sector, just like for any other diseases. And we have enough surveys that the government itself does in terms of health-seeking behavior. So when we say that 80% in urban settings go to private sector and 70% in rural settings go to private sector, these are government figures. These are not our figures. So obviously, it's not it'll be foolhardy to assume that all malaria cases definitely go to the public sector and not to the private sector, because just because you have malaria does not change your health seeking behavior patterns. That is one. The second thing, I guess, is this is again a matter of political will. There was a time when TB was not reported in the private sector, but then the government turned around and that realized that if you really have to take charge of the situation, you cannot ignore such a huge chunk of it. Same happens with several other diseases. It's been kind of a trend. Malaria, again, for a host of reasons, again, has not really got the primacy. Again, this is just another classic case where, so for example, the disease is notifiable, which means the private sector ought to be reporting it. It is notifiable in 31 states. Hardly any reporting happens. You pick up the national stats and you can ask them, okay, how many from private sector? Nothing, almost as good as nothing. So we're now trying to get a central notification done. Hopefully that'll, stir the whole thing. Now, again, this is a political will. So who enforces that? Somebody has to enforce. Somebody has to ensure that, people start reporting. If you ask the private sector, well, for the first thing that nobody's asked them to report, they would want to. Let's say somebody can be convinced that okay, come and report. They would ask, okay, how do I report? What is the system? Is there an online platform? Is it integrated into the national MIS? No, it does not exist. So there are a lot of these pieces which are completely dependent on intent and the government push. And I myself have been a part of several disease control programs in my entire life. And we have seen that, reporting or quality of care is all so heavily dependent on the intent of the government. HIV, the battle was won when private sector players started treating STIs. And they got literally integrated into the system. TB, we are at least doing better because private sector is a part of it and they report diligently. There was a time they were not. So there are enough examples of what was not happening, but then with the government intent, it started happening. With malaria, so far, we hope that the intent comes out stronger. We hope that the government realizes that, especially when it comes to the elimination battle, and we are fighting the last case, if you do not even acknowledge that there is a private sector and there are cases coming in there, how will you ever come close to elimination? So the kind of debate goes on, and I'm sure people in the government also realize that it'll be foolhardy to think of elimination without even looking at private sector data. And I'm not even looking at the informal private sector. That is too nebulous to conquer in any case. But even if you could do the regular chains, the regular hospitals, the regular labs, the certified ones, even that would give us good numbers to allow us to do good programming. So for example, LA lines are distributed if the annual parasite index is above a certain number. And UP does not get an LA9. Why? Because the annual parasitic index is not above 1. Hence, it will not get an LA9. And I'm very sure that if we start truly reporting the cases that come through, we will find a lot of those cases. And I'm sure then the government will have to relook its policy that, why a certain district having an API should get an LNI and the next district should not get it. What's the rationale? Is the mosquito able to differentiate or what is it? So there are several other reasons behind, the policies that then govern basis the detection of the cases from on ground. And how it then manifests into programming, it manifests into how vector control is done, manifests into how drugs and diagnostics get distributed into the the A&M system, the health system, ASHA's A&M upwards, and so on. And there is everything has to do with what are the cases, where are the cases, and how do we report it. I'll give you a very stark example of in 18 when there was a massive outbreak in Badaयूं and Bareilly. Government itself reported several hundred deaths, almost 200. But then if you look at the national figures, UP does not show it there. So it is as stark and as blatant as that. And I don't know if anybody's asking questions.
So do you think the current diagnostic tools and the current treatment protocols is enough? Don't you think that there are certain, challenges with those set of like diagnostics tools, if we talk about diagnostic tools or treatment protocols, or how it is being given to the people, the way, do you think that it needs to upgrade it?
So technology keeps changing, and unfortunately, in the country, we have a very long, gestation period for any kind of new introduction. Although, given the COVID experiences, we have seen them get introduced like in a few days at times as well. Even if it was not as well tested as per norms or whatever, but the government had intent and they pushed it through, and I mean, it has done very well to the country. People have, by and large, remained safe from COVID. And, I wish similar urgency was put to some of the other tools we have as well. We have what we call high sensitive rapid diagnostic test toolkits as well, which can be taken to the last mile, which can detect very low parasite load as well per microliter. But again, it is about how soon can you get in there. And I have a strong feel that should that be interested, we'll find a lot of hidden malaria cases. There'll be a lot of cases which never show as manifest as fever. It's all asymptomatic. You're living with the virus, and your body kind of has become immune to that, and but you still kind of continue to live with that parasite. So there are other technologies like the LLI nets. So we still continue to procure the first generation LLIs. Now we've got into the third generation. God knows when it will come in. Again, it's a regulated product for God knows what reason. It has a few grams into that we put into a net so that the nets can become potent to repel and kill the vectors. And the same set of chemicals get used by maybe the farmer who's using LLI many times more, thousands and thousands of times more in the neighboring field. And that is something allowed by the government. But this one is a regulated thing, can only be given to certain sets of populations where the annual parasitic index is high, is not available in the open market. There are, ridiculous claims like it'll impact the bees, as if, the rest of the chemicals that go onto the field do not attract bees. And, something that you put on the night inside your home will actually be attracting bees. So there are various, I would say regulatory issues also that need to be addressed. And again, it just simply boils down to political intent. If we feel that we have to get into the elimination phase, we have to get to the next generation of LLIs, the next generation of RTTs, the next generation of PCRs, and get the testing done accurately at the last mile. The next generation of insecticide and so on. There are next generation of medicines. We talk about Vivax and falciparum, the two major forms of malaria in our country, and we still see a lot of Vivax cases because nobody takes the 14-day drug course completely. There's huge compliance issues there. But then there are alternatives that are very, the dosage is very substantially small. We need to get that in quickly. So there are technologies, there are tools, there are drugs and diagnostics, and lots of things available. We need to quickly embrace them and take it forward. Otherwise, we will continue to fight a uphill battle, and and as we get closer to elimination, the cases are going to be fewer. And if we still continue to not report, if we still not continue to find the hidden parasite, the hidden burden, and not have sensitive instruments, we will continue to fight this battle way beyond 2027.
So you have been mentioning hidden burden. What exactly is the hidden burden of malaria in India? And also, like since the independence, there have been so many programs for eradicating, controlling malaria. What are like as a human, we have a tendency, we learn from our past mistakes so that we can move on and implement better decisions. So what we need to learn from our past mistakes to stay right on track in order to make India malaria free.
Okay, so the hidden burden is what we call a burden that does not manifest as fever. So you are living with the parasite. It is creating havoc in your system. It is, hitting your liver, your RBCs, and everything. And so you are anemic. You could be stunted. You could be whatever, but it does not show up as fever. Hence, you never get tested, and your body immunity has kind of developed to a point where nobody will detect malaria just by looking at you, and you yourself feel reasonably fine. Because you kind of live with that weakness, that low hemoglobin level, and so on. You are accustomed to that. This is typically a case in highly endemic areas. So areas where typically the parasite has been around for a very long time, like for generations, it's been there, and people have gotten used to it. So the mosquito bite is also fine. The parasite could be living, but because it does not show up with the usual malaria symptoms, you do not go for testing. There's normally not a proactive search that is done. So there's no mass drug treatment or mass testing to begin with, followed by a mass drug administration. And hence, the parasite continues to live inside you for much longer periods of time. But then you could still be a carrier, which means a mosquito can still bite you and infect somebody who's not in that vicinity. And today, with a lot of mobility and all, we don't know who all are going wherever. and maybe passing on the parasite to places where the parasite may not be as endemic. So that is typically the hidden burden. And then we also look at a lot of children under 5 and pregnant mothers who typically should be tested for malaria as well, especially mothers. They get tested for almost everything, but in many cases do not get tested for malaria. So something that we could have picked up, when the child is born, the health system is so far not very strong when it comes to ensuring malaria testing. Again, this is a matter of intent. There was a time when HIV testing was not happening, but then it became mainstream, and today that is one test that really gets done. Maybe tomorrow, with the right intent, we can get malaria testing to be done on pregnant mothers and children and so on. So once we start getting into that space, we will definitely address the pool of the hidden reservoir pool. Yeah. Coming to your second question, what are the, what have been the patterns in history? So very interesting, early 60s, we came down to very low number of cases in the country. And then malaria has this very nasty habit of springing back with a bang. So unless we kind of, when it's kind of going down at the last, we literally take care of it, as in, handle the last case, the last parasite. We never know when it will bounce back. And that is something history has been teaching us. At this point of time, there are good programs, there are resources, there is support to kind of take it to the last mile and ensure that the end game is really met. History will again tell us that if we do not do this well in time and in the window that is made available for such a thing, we never know what the bounce back could be like. There's already climate change happening. There are large tracts of say the hills and other places which typically did not have malaria, but the mosquito populations are migrating, weather patterns are shifting. There's a lot of movement of people internally within a district, within a state, within the country, internationally, and so on. Cross-border malaria. There are so many of these issues that have to be looked into. We are at an opportune time when we feel that if the elimination battle has to be well thought through and driven with good intent and purpose, we could actually do what China has done, which is eliminate malaria. And it's a very good example of a country as big as India, actually bigger, that has managed to take care of the disease. Of course, there are other challenges in terms of China's health infrastructure being far superior to us, and there are other policy issues that one can talk about as well. But it's still the best comparison. China can do it. We can also try and do something about it. And we have the last 5 years of this journey till 2027 to make it happen. And that needs a lot of new inputs, new diagnostics, new tools, innovations, data, intent, intersectoral participation. Literally, we need all hands on the deck to ensure that we actually win this battle.
So as you mentioned in the beginning of our conversation, that we have a program going on right now from 2016 2030. Our goal is to make eliminate malaria by 2030. Like, it's only 8 years left, and in my opinion, I think pandemic has also affected the whatever zeal and was there to eliminate malaria. So do you think that it is possible that we will be able to cover up, now that we have a pandemic also, to achieve our goal by 2030?
So as I mentioned earlier as well, 2030, the goal actually is to come down to 0 cases by 2027. 2030 is a certification space. I think that will be a tall order. Realistically, it may not happen. And again, pandemic also is one of the reasons why we'll be pushed back a little. But having said that, this should be no reason for us to devise the right policies, do the right things, make the right noises, get the political might behind all this. And I feel that with the Prime Minister's clarion call behind this, we have no reason to feel complacent. Prime Minister Modi has fantastic way of galvanizing resources and stirring up the human potential. In whatever he has laid his hands on, he's done fantastically. I've been a part of previous government programs where we used to do sanitation programs, but see, Swachh Bharat is a different animal. So it's about how do you position that program and give it the attention it deserves, put in the monitoring, evaluation, accountability processes behind it to ensure that things really happen. And that is where political will and intent becomes most important. If that is coming, if that is happening in the coming days, things can happen. If it is business as usual, I think we will have a much longer route to elimination. Because very fundamental things like if you're not getting the private sector in, if you're not getting the new drugs diagnostic tools to come in, if you're not using real-time data to identify cases and track them down and literally sanitize those areas wherever those cases come from, how can we think of elimination? And all this, to my mind, just boils down to first actually being honest about it. I would rather recommend to the government that can you come up with schemes where you will incentivize people who report rather than penalize to report, because that's what the norm right now is. And everybody is very afraid to stick their neck out and say that here's a case. And that is a fundamental shift that we need to bring in here. It's somebody has to literally be on rooftops to say that there is no shame in reporting a case. Please do so, and we will ensure that next time onwards, next season onwards, there will be no case there, rather than the other way around. And it's all remaining hush hush, and it's very simple. The ostrich approach will not work in any disease control program.
So anything else that you would like to add?
I think I would only request the media to play important role here, because the political masters, the bureaucracy, the systems, the governments, they also listen to what people have to say, and the way these voices work is very heavily governed by the way the media kind of either tones up or tones down an issue. And this is where I would urge your support. There is a way we can all come together to literally eliminate malaria in a lifetime, because it's entirely manageable. It's not rocket science. It was I go back to polio again. It was just do boon zindagi ke, and everybody came together and made it happen. Malaria obviously is not as simple, but the point is that we all have to come together and make it happen. And it is entirely possible. And some supporters need to come together to join hands in this. And media is definitely one huge supporter that needs to actually start echoing what I have just stated in the last hour or so. We need more voices. We need more intent, and then this gets passed on to the various set of stakeholders who eventually come together to make a difference. The other thing I'd like to also feel that this is not really a government's problem all the time. We tend to keep blaming the government. And even if I did, there was a lot of what I said was pointed to the government. But having said that, there is a much larger role for corporate world, for states, for PSUs, paramilitary, military forces, and so there are several entities in this country. It's not just government and the government health system alone. If all of us can actually put our heads together, literally take this pledge of what the Honorable Health Minister now says is the pledge around Malaria No More Bharat. It is time all of us come together, all of us take that pledge. And we all have our roles defined, and we are happy to steer those roles as well. There's a place for the civil society actors like us. We are happy to create that niche as to what could a corporate do, what could you do in your townships, in your plant areas, in your mining areas, in your whatever communities that you work with. There is a space for that. I'm also looking at the larger spectrum of vector-borne diseases rather than malaria alone, because you can't talk about dengue separately, chikungunya separately, and malaria separately. As a municipal corporation member, for example, you'll be addressing the whole thing as one issue. And thankfully, again, the enemy is common here. It's the mosquito, and the mosquito, not because the mosquito is alive all by itself. It is because of the parasite or the virus inside, and that's what we have to eliminate. So it's important that the media helps us raise the bar. It allows us to raise the right questions and ensure that a range of stakeholders come together and join this battle to realize malaria.
Thank you, Mr. Pratik, for joining us. It was a very informative and very enlightening. Thank you so much for joining us.
It's a pleasure. Thank you so much.